All right, good afternoon, everyone. This is Kristen Woodlock. I'm a COVID-19 volunteer with the New York City Department of Health and Mental Hygiene. This is the COVID-19 webinar for congregate care in residential settings. I'd like to welcome you to this. Today, our main presenters will be Dr. Hilary Cunnins, who is the Executive Deputy Commissioner, and Suzanne Algendi, who is an implementation improvement scientist with the Office of Community Behavioral Health at the New York City Health Department. We can move on to the next slide. Just some housekeeping issues. First of all, this session is being recorded. In terms of COVID-19, our understanding of this pandemic is evolving rapidly. This presentation is based on the latest information and knowledge as of today at 10 a.m. All participants will be muted throughout the presentation. We will have approximately 20 minutes for questions and answers, and we would ask you to please type in your questions and answers. You can do that throughout the presentation, or you can do that at the end when we open things up for questions and answers. In terms of the next slide, we have really a fantastic team that is trying to put this material together for you each week and will be available for the questions and answers. And as we move on to the agenda, I will transition this to Dr. Cunnins.
Thanks very much. Good afternoon, everyone. Thank you very much for joining us this Friday afternoon. Happy holidays to everyone who celebrates. We have a similar agenda. Some of you may have joined us last week. This is an update of the information we provided last week, and we'll be making these and last week's slides available. First, we wanted to share with you a brief update about COVID-19 related local data, and then share with you some of the progress we have made addressing the challenges with staffing and workforce issues, share with you some updates to our congregate care guidance, and highlight some of the areas that this group who joined us last week asked us specifically about. Finally, I will turn the presentation over to Suzanne Algendi, who will speak about opportunities for isolation hoteling or programs with clients in need of isolation. So I think as everyone will be aware, there is still ongoing widespread community transmission of COVID-19 in New York City and around the world, and increasing in countries with infection since last week. It has been almost 6 weeks since New York City reported its first COVID case, and we are continuing to see high numbers of new diagnoses of COVID-19 illness, and including those who require hospitalization. The more positive news is, however, that we may have begun to flatten the curve as New York City data show improvements or slowing down of emergency department visits and hospital admissions. This suggests that our current mitigation measures are working, but it also tells us that we cannot yet let our guard down and continue to reinforce and adhere to these practices. So I want to just share with you a few data slides from New York City. These are also posted on our New York City Health Department website and are updated on a daily basis. And what you can see on the slide in front of you is with the blue bars representing the number of hospitalizations since March 2nd. These have increased in New York City fairly steadily, and in more recent days seems to have flattened. I'll just call your attention to the fact that there are delays in some data reporting, and so we are interpreting what looks like downward trend somewhat cautiously as data fills in over the coming days. And you can keep up with this data should you choose on a daily basis. This is updated every day on our website. The next slide shows deaths among New York City residents, again dating from March 2nd, with the blue bars representing numbers of deaths. Deaths, unfortunately, increased very rapidly since March 2nd. And again, the way we are interpreting this graph is that they are not increasing as rapidly as previously. The decreases may be due to delays in reporting, and we are looking closely at numbers on a daily basis. Finally, one unfortunate statistic which has been in the news both nationally and locally is we are observing disparities in mortality among specifically Black and Latino people, both here in New York City as well as state and nationally. This slide, which is current as of April 6th, shows the rates of fatalities among Hispanics and Latinos. That is the top orange bar, and that rate is 22.8 per 100,000 New Yorkers who are Hispanic or Latino. The next highest mortality rate is among Black New Yorkers with a rate of 19.8 per 100,000. I just want to note that these data, which are based on death certificate data, are complete for only 63% of deaths. We will be continuing to report out this data, and one of the challenges has been in getting complete reporting into the health department. We are very concerned about these disparities, and the city and the health department are undertaking a number of efforts to address specifically this disparity. I want to next turn our attention to challenges around workforce. We are continuing to hear from many providers around the city that making sure that their clients and residents are safe is particularly challenging when staff members are unfortunately, like other New Yorkers, experiencing high rates of illness and absenteeism. I shared with you last week that in some instances, the Medical Reserve Corps, which is a New York City Health Department resource consisting of volunteers from both the city and outside who can assist with staffing, is available if you need it. You can see the link to the SurveyMonkey down at the bottom, and I've received feedback from our colleagues who are coordinating that resource. If you make a resource request from that website, to fill it in with as much detail as you can about what skills you are in need of and what role the person would fill. As we discussed last week, that resource has folks from the healthcare sector who are mostly licensed professionals, both physical health and behavioral health professionals. And we know that that doesn't include all of the workforce needs that residential providers have. So I'm very pleased that we've made progress since we spoke with you last week in setting up what we are calling a Congregate Care staffing portal. The staffing portal will support New Yorkers to continue to be able to receive care in their current congregate site by assisting providers to identify rapidly temporary or even longer-term staff. The portal will be operated by our partners at the Coalition for Behavioral Health, and the goals are to expedite access to relief staff for providers and also help track trends and anticipate potential issues related to staffing at the earliest possible moment without burdening providers with surveys and phone calls. We anticipate the portal will be live early next week, and we will communicate with New York City providers as soon as it is available for requests. We are initially going to make it available as a wave 1 to not-for-profit congregate residential settings licensed or funded by the following organizations: New York State Office of Mental Health, New York State Office of Addiction Services and Supports. That line is, we're holding off on Office of People with Developmental Disabilities who may have specialized staffing needs, which we will address shortly. And New York City Department, apologies, I misspoke. We had some back and forth before this. New York State Office for People with Developmental Disabilities will be included, and providers in contract with New York City Department of Health and Mental Hygiene. We anticipate once the portal undergoes an initial week or so of testing to make sure that it will adequately meet the needs of providers, we anticipate opening it up to wider eligibility to a range of behavioral health programs across New York City. So again, there are 2 workforce resources for providers. The first is the Medical Reserve Corps, which has volunteers, so both in physical health care services and behavioral health services, typically who are licensed, and the staffing portal for paid workers that will be managed through the Coalition of Behavioral Health Providers. Next on the agenda is I want to return to some of the guidance topics that we began to address at our last meeting on last Friday. We have a slightly revised guidance posted, in part based on some of the feedback that we got last week. And I wanted to just share with you a few key points from the guidance that came up in the questions and answers. First, we have available a number of communications devices, posters that you can see there that are available through our website to download and reproduce, which can help more easily communicate with staff and clients. The next slide shows a number of key points around preventing the spread of COVID-19 in your facilities. And we talked about pretty much all of these last week. I just want to highlight something new since last week, which is the bottom bullet. Staff and residents should wear face coverings. This is a recommendation a new recommendation by the city that when all of us are in public, we should wear a non-medical face covering. This can be a simple t-shirt or bandana. We've probably all now seen examples of homemade versions of this. We are recommending for staff and residents in congregate providers as a suggestion to wear face coverings when folks are out of units and in common spaces. Another question that came up last session is issues around visitors. A number of you asked whether we could issue an order to prevent visitors. We investigated this, and we are able to provide this as a guidance or recommendation to cancel or severely limit visitors and to suspend non-essential visits. And we encourage all of the providers to speak to their own counsel about whether, particularly in situations where tenants hold individual leases, to be able to entirely prevent visits. We have gotten feedback, though, from providers who have posted signs, spoken with staff and clients about visits, and it has, to our knowledge, been very successful in reducing unneeded traffic in and out of buildings. That is just by recommendation. Another set of questions that we received last week in our session is a little more detail about how to manage residents who could have symptoms or have confirmed COVID-19 illness. So again, as we discussed last week, more than 80% of people who have symptoms of COVID have mild illness and get better quickly. A minority about 20% may develop more serious illness and may need hospitalization. Some of the risk factors for more serious illness include older age or other health conditions, which you can see listed here, some heart problems, lung problems, or diabetes. It may be in these cases, and our recommendation is if a person does not feel better after 3 or 4 days, to consult with a healthcare provider. You can encourage a client to contact their own health provider. If they do not have one, they can call 311 and will be connected to a provider through Health and Hospitals. And so if resident symptoms persist or worsen, encourage a phone call to a medical provider. Urgent medical care is recommended, and I think the following is probably makes a lot of sense even for folks who are not without medical training. If a resident has difficulty breathing, persistent pain or pressure in the chest, seems confused, has difficulty staying awake, develops bluish lips or face, or any other condition which seems emergent, we encourage people to call 911. I know messages around avoiding unnecessary use of 911 are also important, but if someone is in medical straits, we do recommend relying on EMS, which will respond to a medical emergency. Another area of questions that we had from last week is when isolation can be discontinued. And you can see here the guidance to stop isolation. These criteria are when at least 7 days have passed since isolation started, and either the person never had a fever or has not had a fever in the last 3 days, and overall illness has improved. So we have been referring to this internally, a little bit of shorthand is the 7 and 3 criteria. 7 days since isolation started, and at least 3 days with no fever and overall improvement of illness. I also want to highlight a new brief section in our guidance based on other questions that have come in to think about some additional considerations for residents who might have addiction or be actively using drugs. Just want to highlight that before COVID, many of us were working on the overdose epidemic, and in particular during this time of physical distancing, where people might be using drugs by themselves, may be at increased risk of overdose. So we encourage facilities that may be aware that some of their clients are active drug users to think about instituting safety checks in common or other bathrooms, and to consider having the lock zone available on the site or in residence rooms. You also might be maintaining awareness that clients who have a physical dependence on heroin or other substances may be looking to exit the facility to use drugs in order to manage their withdrawal. And you may end up being aware that there is some drug use in the facility, and think it's important to talk with staff and clients about ways to reduce risk and to minimize both risk of overdose and withdrawal. One way to minimize risk of withdrawal in the case of opioids is to offer clients treatment with medications, in particular methadone or buprenorphine. Buprenorphine is available telephonically or by video, and that information is also available on our website. We also spoke at our last webinar last week about tips for keeping folks in congregate care settings both active but also socially distant. We got a lot of great ideas on the chat box last week, and we wanted to summarize them for you here. I'm sure there are many more, but we thought these were really fantastic things that different providers have already tried or we're thinking about trying, both around activities that can be done remotely or in a socially distant fashion, as well as some environmental changes that can help residents and staff remember to keep 6 feet or more apart. We have additional resources. They are available up on our website. One thing which I didn't mention already is we have a number of mental health resources, and new ones coming up gives you tips to talk to residents and staff, colleagues, friends, and family about normal reactions to the pandemic, different feelings and symptoms people might experience, and also ways to talk about loss and grief, which are fortunately part of all of our daily reality now. I'm going to now turn the presentation over to my colleague, Suzanne and Elgendi, who will speak about updates in isolation hoteling.
Great. Thank you so much, Dr. Cunnins. Last week, Dr. Cunnins and Dr. Harrison briefly mentioned isolation hoteling, and we have a couple of more updates to provide you this week so that you can start accessing isolation hoteling through your congregate care settings as appropriate. So New York City congregate residential settings licensed or funded by the following entities are eligible for isolation hoteling. So those include programs funded by the New York State Office of Mental Health, the New York State Office of Addiction Services and Supports, the New York State Human Resource Administration, the New York City Human Resources Administration, and the New York City Department of Health and Mental Hygiene. These hotel rooms are available to New Yorkers who may have had symptoms of COVID-19 or who have been diagnosed with COVID-19 and meet the following criteria. First off, they are not able to isolate where they live. So we do encourage residents living in congregate settings to try to work within those settings to isolate in place where possible, whether that means rearranging sleeping arrangements or separating bathrooms or separating residents by floor, by ill and non-ill residents. We encourage that first. But if those solutions don't work, then isolation hoteling can be a possible option for those residents. In addition, the residents do not need COVID-19 related medical care. The isolation hotels do not have medical staff on site, and so are primarily for medically stable residents who can simply isolate in a hotel for the 7+3 days that Dr. Clennings mentioned a few slides back. So in addition, if the resident requires ongoing services, the provider needs to be able to continue to support at the hotel, and that can include remotely, whether that's telephonically or via video as well. In addition, I just want to mention that residents who participate in this hoteling program, in the isolation hoteling program, also need to understand the need to remain in the room for the 7+3 criteria, the days that we mentioned, and also must be able to independently manage activities of daily living and monitor their symptoms. If we could advance to the next slide, that would be great. Thank you. So the isolation hoteling program has a couple of different pathways in. So persons who are eligible for this program can be referred by hospitals. So that may be patients who have had COVID-like illness or were COVID positive and are now stable enough to be discharged from hospital, but need a safe isolation space and can't return home to their typical residence. We also have a route in through the Department of Homeless Services, so there is a separate route for those individuals. But today we really wanted to focus on the route in through for behavioral health congregate care settings. So we will discuss this in more detail on the subsequent slides. So for isolation hoteling in this context, the Supportive Housing Network of New York, or SHINE, is going to be the point of contact for isolation hotel reservations by behavioral health congregate sites. In other words, the behavioral health congregate sites won't make the hotel reservations directly, but they'll work with SHINE, so they would contact SHINE to indicate when a resident may be in need of isolation hoteling, and Shinny would in turn make the reservation and relay the information to the behavioral health congregate site. And I will, in a few slides, go through the details of that process so that it's clear to everybody on the webinar. The congregate care agencies provide instructions to determine, are provided instructions to determine if an isolation hotel placement is appropriate for a specific client. So that will include some instructions and a checklist about different strategies that have been tried and the resident's ability to isolate alone for and complete activities of daily living for the required amount of time in the hotel, amongst some other criteria. If the client is in fact appropriate for the program, the agency should contact Shinny, as I mentioned above. And isolation hoteling is a last resort option. So we really prefer to have residents isolate in their typical residence, in their congregate setting. But if that's not possible, then isolation hoteling should be used as a last resort. We can move to the next slide. In terms of what services are provided at the isolation hotels, the hoteling program will provide transportation from the congregate care site to the hotel. The hotel will also provide 3 meals per day that will be delivered to the resident in their hotel room. Laundry services will also be provided for both linens and personal items. And residents will also be provided phone and Wi-Fi, which is important for some of the wellness checks that we're going to discuss on the next slide, and other provision of services that the typical congregate setting may need to provide while their resident is in the isolation hotel. So we can move to the next slide. So now, in terms of what the provider must continue to give the resident, there's a couple of different items on this slide. So the first is twice daily telephonic contact with the resident, and this would be to check in on the resident's emotional wellness and their physical health. In addition, if face-to-face contact is required at the hotel, the provider would need to continue to provide that for the duration of the resident's stay in the hotel. So if this could be in place if the resident has difficulty with self-isolation or requires additional services such as medication or has dietary issues or restrictions. The provider would also need to be in close communication with the resident and the on-site hotel coordinator. And this is around planning for dates of checkout and to ensure a smooth return home. The provider would also need to coordinate access to nearby medical services or hospital as needed. Although, as I mentioned previously, this program is generally for medically stable individuals. And so this may be in the case if somebody needs an appointment or some other medical service that's routine, that would need to be coordinated with the provider. But there are no on-site medical services at the hotels. And then the provider would also need to coordinate transportation from the hotel back to the congregate resident. So I mentioned on a previous slide that transportation is provided from the congregate setting back to the hotel, but getting from the hotel back to the congregate setting falls on the provider. And there also needs to be on the side of the provider the coordination of medication and prescriptions, so that could be delivery of such services to the hotel as needed. And the provider would also need to bring daily necessities such as toiletries and replenish this as needed. And so this can be done in the form of having delivery sent to the hotel front desk for delivery to the resident. So if we could go to the next slide, that would be great. So to give some more concrete steps on how the isolation hoteling process, referral process works, as I mentioned, Shinny will be the point of contact for isolation hotel reservations by behavioral health congregate sites. So a couple of different steps need to take place in order for a successful reservation to happen. The first is that we will be providing contact information to agencies in terms of how to contact Shinny. And then Shinny will be available from 9 a.m. to 5 p.m. 7 days a week in order to facilitate hotel reservations. So when somebody from an agency or congregate site contacts Shinny, we just ask that you please be prepared with demographic information and isolation needs information and support that are specific to the client. So for instance, this could include information such as desired check-in date, a need for an accessible room, refrigeration or refrigerator needed for medication, if the resident has any service animals, and if there are any dietary restrictions. So anything that would help the hotel reservation staff and Shinny understand what type of room would be most appropriate for the resident would be really great to have on hand. So Shinny will then make the reservation. They'll call a central hotel reservation line and make the reservation on behalf of your congregate setting. And then Shinny will then relay the details back to the provider, and the provider would give the reservation code to the client, and the client would present that code at the hotel upon check-in. So those are the 6 steps to completing the reservation. And if you have any questions about, if you're from a specific government agency, you can contact your point of contact at your agency for further information about this. But Shinny will generally be the point of contact for many of you on this call. And so I think we can go to the next slide. Okay, so
Thank you.
Turn it over to Kristen for Q&A.
All right, terrific. And we have some very, very thoughtful questions that we have already queued up. I would invite you, as we start the question and answer period, if you have additional questions or follow-up questions, feel free to type them into the Q&A box that you'll find on your right, and we'll add those. As you've seen in today's webinar, if we aren't able to get to a particular question, that is something that we can look to address in a future webinar. So our first question is the decrease or leveling that you described in terms of hospitalization, is that related to a change in strategy about treating people in the community, or what do you attribute that change to?
So that is a great question, and I think that is, I'm pausing so I can answer it as clearly as I can. I think our hope, based on those data, is that it means that rates of infection are slowing in the community, and then it means that there are fewer numbers of people with severe illness who need hospitalization. I think what remains uncertain here, and I know there are some questions about testing that have popped up, is that unfortunately, testing remains in short supply. The reason for this is twofold. One is that the supply chain for testing materials is not widely available. And until now, though that may change soon, testing requires that health professionals wear full PPE with masks and face shields. And we know also that PPE remains in short supply. What I think many people anticipate is that as testing becomes more available and we as a country, as well as a locality, are able to do more widespread testing, we'll be able to know about transmission both from less sick and more sick people. So that all is to say that we are tentatively and optimistically interpreting slowing rates of admission to hospital as being evidence of slowing rates of transmission in the community. And Kristen, I just, before we go to the next question, I just want to clarify one of Suzanne's points about the hoteling. We are all very excited to begin to see this as a good option for folks on the phone and more. We wanted to just clarify that we anticipate that this is most appropriate for settings where there are shared bathrooms and kitchens and bedrooms, settings that is the most difficult places to keep folks with symptoms or confirmed infection apart. I'll also add that the providers should have gotten a letter to say they're included in the program by their city or state funded agency, and those letters have Shinny contact the correct contact information on them. So when you go back off the telephone, ask your program directors about this letter, and there will be additional contact information in that.
Okay, thank you. So just sticking with that testing, we have one question that's coming in from a federally qualified health center that has some OASIS programs, and they're wondering when they would be allowed to do testing for people who are in residential treatment, who, so that they can help residential providers understand who's positive and who's not. And so maybe we can finish that up on what you were just discussing in terms of PPE.
Yeah, that's also a relevant question. So right now, in this time of widespread community transmission and limited testing, our recommendation in terms of thinking through with residential providers how to separate people who are potentially infectious is our recommendation is to regard people with symptoms of COVID as having COVID. So the symptoms, which we didn't review this webinar, are fever of 100.4 or greater, or feeling feverish, or a new sore throat, new shortness of breath, or new cough. Any one of those symptoms, we want providers, all New Yorkers, to consider themselves as having COVID. And again, this is in a time with widespread community transmission. We want to count those symptoms as COVID, and that would therefore lead us to recommend isolation for that person, even in the absence of testing. This makes sense at a time like now when there's widespread transmission and there aren't other or many competing illnesses that could be confused with COVID. So, for example, there's really no influenza circulating right now. So those symptoms are most consistent with COVID, and recommendation is to isolate. It is possible in the future, when there is widespread testing available, that recommendation would change.
Okay, thank you. Next question is, is there any reporting or notification that a program should be doing if they believe or know someone has, COVID-like illness or COVID-19, they won't comply with isolation and they opt to leave a program?
So that is also a great question. So just on the reporting element in general, and this has changed over the course of the last couple of months, is we don't require or ask programs or facilities to report COVID illness. At the beginning of the epidemic and the beginning of widespread transmission here in New York City, we were doing contact tracing of individuals who were ill. But again, with widespread community transmission, our efforts have moved from containing the infection to mitigation. In the case of somebody who is not adhering to isolation, there are no orders that we are currently issuing. We want to minimize law enforcement or other interventions, particularly when there's so much need for first responders in so many places. We are recommending, again, universal physical distancing. So even if that person were to go out, everybody else should be trying to stay 6 or more feet away from that person. That said, for folks who have relationships with one of your state agencies or want general advice and sort of talking through problems in your setting, we are available, and the other state agencies, I'm happy to speak on their behalf, are available to problem solve and try to think about ways to approach this from a behavioral perspective. Last week's webinar, we talked about using behavioral and other incentives to try to support clients to adhere to whether it's isolation or using a particular bathroom or maintaining social distancing as one of many strategies to try to implement.
Okay, thank you. Next, do we have any information that we can share at this point in terms of understanding, why there are disparities in terms of COVID-19 with people of color?
So I think, let me answer that very broadly, which is these are racial disparities that get replicated in many of the disease conditions, if not all, that we see in our country. We know, like every other health condition, there are many social determinants, including structural racism, including unequal access to housing and unequal access to higher paying jobs that drive the disparities we're seeing. So at this point, we hypothesize that the same factors are at work. Folks who might have less ability to socially isolate in place because of more crowded living conditions, folks who might be in jobs that offer less protection because less ability to physically distant and so forth. I think we at the city wanted to get this information out even without all the answers so that people are aware of these racial disparities, begin to name them, and to think about ways to take action and protect people who are at particularly high risk.
Okay. In terms of, being able to clean a bedroom or a bathroom that was used for, the 7 and 3 days with a COVID client or a COVID-like illness, is there guidance that someone can get in terms of what process would be most effective or something that you could speak to at this point?
Sure. So we have one good thing about this particular virus, and different from other viruses, it is susceptible to routine cleaning products. It is not, though there is some evidence that it can live on surfaces for some period of time, it is very easy to destroy using routine cleaning products. There's information on our website about which cleaning products are effective, and perhaps when we post the slides up on the website, we'll include a link to that in our links page. So just routine cleaning does not need special sanitizing is sufficient. That is true for bathrooms and kitchens as well.
Okay, great. And just because you did just mention it, there have been multiple requests to ask if the slides would be available. So I just want to confirm that you just said we would be posting the slides and that we're responding to those who typed that in.
Yes. Okay, great.
Are the numbers that you showed in terms of the data around COVID-19 deaths, is there a distinction that those are only people who have actually been tested for COVID, or is that people who are, are believed to have COVID-like illness?
Yes. So right now, the deaths that are posted on our website are deaths of people with lab-confirmed COVID illness. And for those of you who might be following the news, there's an excellent piece in the New York Times, either today or yesterday, about the ways in which that could be undercounting deaths. So again, because of the difficult situation we're in, where testing is a scarce resource because of supply chain problems, fewer people are being tested. Testing is being prioritized right now in New York City for hospitalized patients. We know we are undercounting deaths. We are undercounting deaths for folks who might die at home or for folks who do not get tested before their death. So there is will be work to better estimate the total number of deaths, and I think those estimates will certainly go up as we incorporate them into our counts of people who are lost to the pandemic.
Okay, thank you. we have some more, a group of what I might call more, logistical or technical questions. So the workforce, the staffing portal that you discussed in the webinar, will that be available to people who are outside of New York City?
So right now, this is being made available to providers in New York City. It's being funded by New York City Health Department, and hopefully, we want to make it available as to many people as possible, but for now, in the 5 boroughs.
Okay, great, thank you. And is for the isolation hoteling, are those hotels available throughout the 5 boroughs, or are they located in just a borough or 2?
I can speak to this one. This is Suzanne. We are working with our partners at NISM to make sure that there are hotels in all 5 boroughs. And when you work with Shinny to make the reservation, you can indicate your location and the preferred location for the hotels, and the reservation center will try their best to match your desired location with a hotel or for your clients.
Great, thank you. And Suzanne, this one might come to you as well, but do we know, and I'm reading into this question, that there might be some concern that the letter that you discussed that would go out with the details might be mailed to someone's office location and they're working remotely. So the question was, how would we get that communication? Will that come to our agency via email, or what I would refer to as snail mail? Do you have any knowledge of that?
Yeah, as I understand it, those letters are going out via email.
Okay, great. So I believe we have addressed all of the questions that we've received on the Q&A. Just to give you another minute or two if you have a question that you would like to add. Or anything else, Dr. Cunnins, that you'd like to address?
No, I think we've covered it. We are interested in keeping this provider community up to date, and others. We want to try to solve the problems that are happening at all of your sites. We know that this is an extraordinarily difficult time for your clients, your residents, for yourselves personally as New Yorkers. I really do want to extend my gratitude for all of you who are joining today, for your colleagues and residents for hanging in together during what is, I know, for all of us, an unprecedented time. I'm very grateful to all of you also for many emails, for questions, for advice, for feedback, and we are taking it all very seriously and trying to meet the needs that we're hearing about as quickly and as comprehensively as we can. So thank you all.
All right. We did get one more question, if we have time for that. So do we know how long the process is from referring the person? This is an isolation hoteling question. From referring the person from the particular program to the hotel, what the duration of that would take?
Sure. So that should, when the reservation is being made, the point of contact at Shinny will indicate to the hotel reservation center when the client needs to check in or when the resident needs to check in. So we'll try, the hotel reservation staff will try their best to expedite that and make sure that the resident is able to check in as quickly as possible. I think we're all trying to move this as quickly as possible. So we'll try to meet the needs of the particular resident.
Okay. And this is a question for you, Dr. Cunnins, that if someone arrives, I don't know what type of program this is, but if someone were to arrive at a congregate care program with a severe cough and is suspected of COVID, what should the program be doing?
So if this is I'll take this as a new client, or I suppose it could be an existing client. I think the priority is, of course, to make a determination if the person needs urgent medical attention, sort of using some of the criteria that I mentioned before. If what is more likely, the person has mild illness, the person should simply be isolated in their, asked to be self-isolated in their room, and to strategize support so that that person can be helped to stay in the room, whether it's arranging for meals or food to come up to the room, and we talked about this a fair amount last week, to think about how best to keep the person either in their own bathroom or to encourage quick, rapid cleaning when the bathroom is shared. I think as we know that that is not ideal or possible for all clients at all times, and that's why we worked hard to set up the isolation hoteling option. I do want to share with everyone, and I know Shinny is on the call hearing this. This has been really a collaborative effort across many parts of government, and with Shinny and others, as well as feedback from many of you on the call and your colleagues in other congregate settings. We really want to see this be a useful and effective program, and we want to get feedback, I'm sure we will, about how you all can best use this to make decisions like the case that Kristen just read to me, as well as others.
Okay, this is an isolation hoteling question that, are residents who are in the isolation hotels allowed to leave at all, or must they commit to staying inside for the entire time that they're there?
Yes, this is Suzanne. They need to commit to staying inside the entire time that they're there. Although, as Dr. Connens was saying before, there is no order, enforcing that if somebody leaves, that there'll be a repercussion. But we do strongly urge people to stay in their rooms, because the purpose of the rooms is to support recovery and prevent spread of COVID-19 in the community. So the expectation is that they would stay in the room for the duration.
Okay, thank you. Well, we have addressed all of the questions. I will just turn it back to you, Dr. Connens, just to close us out. Thank you, everybody.
Yep, thank you all very much. I think our goal is to continue to have these webinars periodically. We've done 2 in 2 weeks. We will gather during this week and see if there's enough new information to share next week. We are interested in sharing information that people will find useful, and are very open to continuing this method of communication. So thanks all. Thanks to Kristen. Thanks to Suzanne and the other panelists who are at the ready to help me and Suzanne answer questions. So have a good day, everyone.